City of Hope up to the podium.
Thank you so much for the opportunity to discuss the recent advances of the immunotherapy and the PARP inhibitors in the gynecological cancers. Can I have this first?
We're pulling up the slide.
Yeah. I'm a medical oncologist specialized in gynecological oncology at the City of Hope. Seems it doesn't work. Yeah, the landscape of gynecological cancers has been changing, and the mortality of cervical cancer and ovarian cancer had been declining, but the uterine cancer has been increasing. For the first time from last year, uterine cancer becomes the leading cause of the cancer-related deaths in the U.S. Women. And the gynecological cancers account for 11% of all cancer-related deaths in the U.S. women. And in the next few minutes, I will discuss the immunotherapy and the PARP inhibitors in this field. And for the immunotherapy, let's start with the uterine cancer. And there's a lot of studies showing that initially from the pembrolizumab, we had been using it for treatment of uterine cancer with the biomarkers with the MS high and MMR deficient and the TMB high patient had been working, but the response rate is not so high. And then later we have the pembrolizumab combined with the lenvatinib. That's part of the study of 309, and that's for the MMR proficient patient. And then we have the docetaxel and the pembrolizumab and the durvalumab from last year is moved to the frontline treatment in combination with the carboplatin and paclitaxel. That's based on the study for the RUBY trial. The RUBY trial and the GY018 trial, and also the DUE trial. I'll also list this one here in the adjuvant setting, and we'll discuss a little bit about that. In the same issue of New England Journal of Medicine, that's in 2023, they published the RUBY trial outcome and also the NGR trial. In this trial, RUBY trial used docetaxel and combined with the carboplatin and paclitaxel, and then maintained with the docetaxel for 3 years. For the NRG GY018 trial, it's combined with the pembrolizumab and the carboplatin paclitaxel and maintained with the pembrolizumab for 2 years. And initially, the RUBY trial published in the New England Journal and then updated the result last year. That's in the Annual Oncology for the overall survival data. You can see the progression-free survival in all these groups is separated pretty well, but the overall survival, some of the groups, especially in this group, is separated pretty well, but it's not mature yet. The overall population and also for the patient with the MMR proficient patient also separate pretty well, especially this group. In this year ASCO meeting, they updated the first time, the time to first subsequent therapy, and the time to second subsequent therapy. And you see the two groups is significantly prolonged for the for the first second therapy and the second subsequent therapy. The time is prolonged. And then let's move to the trial with the pembrolizumab here. And the NRG trial published the updated outcome, the recent result that's in the Nature Medicine early this year. For the MMRP proficient population, the progression-free survival, and also in this group, is pretty significantly prolonged. But the overall survival in this group is not that much. It's not significantly different. But in this group, it's not mature yet, but favored the group with the pembrolizumab. And the NCCN guideline and endorsed the treatment with the pembrolizumab, but that's based on the RUBY trial. And this is the pembrolizumab, the NGR trial, the dostarlimab is a RUBY trial, and a DUE trial. And specifically in this group, the stage 3 and stage 4 dMMR patients, but the patient has no measurable disease, just recommended to follow this trial. And this is a similar treatment with the NGR, with this one with the pembrolizumab, but maintained for only 1 year. And here, let's move on to the cervical cancer. Cervical cancer, we had been using pembrolizumab for treatment of the PD-L1 positive patient, and then we combined with the chemotherapy in the frontline treatment. And for now, recently, there's a publication from this trial for the atezo is also moved to the frontline treatment. And here, this trial, I'll focus on this trial to look into detail with the pembrolizumab combined with the definitive chemoradiation. It's regardless of PD-L1 status. This one, we need a PD-L1 to be more than 1 as positive. And for the atezo, it's regardless of PD-L1 status. And this one, we do not test for this. And this is the initial, this is the communication in the ASCO meeting for this year. For this trial, and they published all the final survival from the phase 3 study. In all the cancer, several cancers, it's not a candidate for surgery. From that's with the nodal disease, and for stage 1, B2 and 2B, and also for stage 3 and 4 without nodal disease. Also, it's not a candidate for surgery. It's randomized to 2 groups. One group received the definitive chemoradiation combined with the pembrolizumab, and this one with the placebo, and it lasted for 2 years. And you can see the interval analysis at 24 months and 36 months, there's a huge difference there. For the overall survival, there's also a significant difference. And here, the subgroup, you can see if the early stage seems to not benefit too much, and compared to the later stage, stage 3 and stage 4, and it's a huge difference there. And the NCCN guideline endorsed the treatment incorporated with the immunotherapy combined with the definitive chemoradiation for the stage 3 and the stage 4, specifically because this trial used the staging system of FIGO 2014. It's not the most current one. And some others, immunotherapy here is a combined pembrolizumab combined with the chemotherapy that's only for the PD-L1 positive patient. And for atezo, it's regardless of PD-L1 status. And some other combinations, we don't have time to review for that. And here for the ovarian cancer. Ovarian cancer, immunotherapy does not work well for the ovarian cancer. There's a lot of studies. I listed a few of them, some of the phase 2 studies. This one actually is endorsed by the NCCN guideline, and all these 3 studies, phase 2 studies, including interleukins and CAR-T and a vaccine combination with the PARP inhibitors and other agent. Actually, none of them has been approved by the FDA. And the NCCN guideline just highlighted, just endorsed this combination for immunotherapy. That's based on the phase 2 study from the Russell Park group. So let's take a look at the study. Initially, they published in JAMA Oncology, that's in 2021. And they recruited 40 patients altogether here. And the response rate actually is about 47.5. That's very impressive for the patient who received multiple lines of chemotherapy. And the combination actually is just the cyclophosphamide with bevacizumab combined with the pembrolizumab. This two actually we've been treating the ovarian cancer with this two for many years. The response rate is only 20%. It's not that much after 3 lines of chemotherapy. Usually the standard chemotherapy, the response rate is only about 20% of this two. But combined with the pembrolizumab, the objective response rate increased to 47.5, and the clinical benefit rate is 95. is 95%. Most of the patients received get the benefit. And you can see the waterfall plot shows most of the patients get the benefit from the treatment, and some of them have a durable response, lasts for many years, and here the longest one is more than 2 years. But in this year ASCO meeting, there's one abstract showed that it's a question that is more always better here. Is that means the combination of the 3 and also or just only 2 cyclophosphamide combined with the bevacizumab or combined with the pembrolizumab. Actually, this showed no difference. There's a lot of patients here. It's 136. I'm sorry, you cannot read it. Here is a 37 patient. They claimed that there's no difference. Actually, if you read the reading number here, the objective response rate here, the 2 combinations is 20%, and the 3 combination here is only 21%, compared to the 47% reported by the in the JAMA oncology. That's pretty far. But from here is the clinical benefit, all this, including stable disease, you see it's only 40% around. Both of the group, it seems there's no difference. So after the publication of this paper, so at City Hope, we treated so far about 100 patients. You can see this is an interval analysis of 47 patients. You see we got a similar result. It's a lot of patients get the benefit. It's around 40%. Some patients progressing. It's not as good as the data published by the Roswell Park, but it shows that around 40% of patients get an objective response rate, and most of them, more than half, get the clinical benefit. But we still think the combination of pembrolizumab combined with the bevacizumab and cyclophosphamide is an effective trial. Because the rationale, this rational combination, cyclophosphamide to suppress the Treg cell, and bevacizumab can induce a hypoxic condition to make the the cancer cells respond to the immunotherapy. Yeah, let's move on to another trial. It's the oncolytic virus trial. It's a phase 3 study. Shows a very good result. Preliminary data shows that is a promising treatment strategy. We are one of the site of this trial. We published the trial in this 2023 in the International Journal of Gynecologic Oncologic Cancer. And the trial is for the patient with the progressive disease, and after at least 3 lines of chemotherapy, you get into the trial, randomized to the experimental trial here, experimental arm, received 2 doses of intraperitoneal injection of the virus, and then treated with a platinum doublet. This is all for the platinum-resistant refractory patient, but you treat the same thing after the virus injection, and they claimed that from the phase 2 study, this virus infection can make the cells more sensitive, make the platinum-resistant cancer cells become sensitive again. And here the data from the phase 2 study. You can see from the radiographic response, most of the patients responded, and the C125, the tumor marker for ovarian cancer, is reduced. Actually, the progression-free survival is the 2 curves separate pretty well. Even for this one, it's around 11 months, more than doubled of the control arm. So we treated already 4 patients at City of Hope. So all of the patients responded, and there's still 1 patient is still on the trial, and is still with a continued with a durable response. Okay, the PARP inhibitors. We have 3 PARP inhibitors for ovarian cancer from 2014, initially approved for treatment of BRCA1, BRCA2 mutation patient with olaparib. But there's a lot of indications after that. But for now, there's only a few of them, 5 left over. And some of the indications approved by the FDA is withdrawn. olaparib, we still have three indications here. It's a recurrent disease for maintenance that's required platinum-sensitive status, and the frontline single agent at the frontline with the combination with the bevacizumab, and based on the POLY-1 trial and the SOLO-1 trial. We'll go over about these two trials. And the niraparib is also approved after the olaparib. There's several indications for now, it's only in the frontline treatment. But even the HRD group, the overall survival is not quite significant. Rucaparib has, because of the company issues, is not, most of the trials is suspended, but keep the one of the indication there. The medication is still in the United States. I have still a patient on this medication because of the toxicity to the olaparib, but we switched to this one. It works pretty well, but there's no more active studies for rucaparib. And for the SOLO-1 study, initially they published in 2018. And the progression-free survival is huge, it's significant. And that's the single agent, use the single agent for the olaparib single agent for maintenance. And 7 years later, you can see the overall survival, even the curve separated even more. And it seems that is the patient get the benefit. The group on olaparib after almost 10 years is still not 50% yet. And they published also the time to the first subsequent therapy. That's the most the recent one. Here, there's to the first subsequent therapy is prolonged, and even the second subsequent therapy is also prolonged pretty well. And for the combination, that's based on the POLY-1 trial, and the progression-free survival is significant. And that's in 2023, they published the overall survival benefit for the group of HRD positive and the BRCA1 mutated patient. But for the HRD negative patient, there's no significant benefit. And for now, for the PARP inhibitors, with the benefit to the patient, especially for the HRD positive patient and BRCA1 mutated patient, but they have a significant toxicity. And the fatigue, nausea, vomiting is pretty significant, but this is manageable, including the bone marrow suppression. But there's one set, the complication is the MDS and leukemia. You can see for after subsequent lines of chemotherapy with the PARP inhibitor, in the prior study, the experience of from AstraZeneca is around 8%. In City Hope, we have 6 patients complicated with leukemia. It's kind of pretty sad. And for the SOLO-1 trial in the front line, actually, is only 1% is manageable. And for now, there's several combinations with the immunotherapy and the PARP inhibitors, but none of them has been approved by the FDA. And the DUO trial is positive, but it's not approved by FDA yet. And this one, the combination, the OV43 is combined with the pembrolizumab and olaparib. It shows the clinical benefit. And the first trial just published the data with the statistical difference, but it's only 1 month prolongation there. And a DUE, that's a combination for the endometrial cancer combined with the niraparib, with the olaparib. Yeah, the immunotherapy is now a standard treatment for endometrial cancer in the front line, and also combined with the other treatment in the subsequent lines of chemotherapy. And also for the throat cancer, it's integrated into the chemoradiation and the systemic therapy. Immunotherapy in the ovarian cancer is challenging. None of the trials has been ever approved by FDA, but it's still under investigation. And the PARP inhibitor is a cornerstone for the ovarian cancer treatment, but have the significant toxicity needs to be managed. In the future direction, with the optimize the combination, biomarker-driven, and the resistance management, I believe that in the future, in the immunotherapy and the PARP inhibitor may cause a significant change to the landscape of gynecological cancer treatment. Yeah, will stop here.
Wonderful. Thank you, Dr.